What about protrusive? How often are you messing? See, like, I remember when you and I spoke years ago, you said you rarely do protrusive.
In a patient who has, you know, a lack of protrusive disclusion, then we would do it. Okay. So like her case, she has a lack of protrusive disclusion in the early movement because she has no real steep, she doesn't have much overlap, so she's got back teeth in play. But if it's someone who has an open bite, or someone who has you know, tipped up molars, you know, then it's worth looking at protrusion. If they have a missing first molar, that second molar on the bottom is tipping up, they're going to have lots of protrusive interference.
And you generally just do the temporalis and the masters. You don't mess with digastric and cervical master in general.
The direct relationship is between the molar periodontal ligaments and those four muscles, the master temporalis, lateral pterygoid, and medial pterygoid. Okay. But in some people who will say things like, I have a lot of neck problems, no one's been able to tell me what's wrong, or I have really tight throat, then I will go and
they'll come and tell you
the digastric. Yeah, they'll say my throat gets tight, my tongue feels big, I can't, sometimes my jaw feels like I can't breathe. You know, then we'll measure those other muscles and see if there's an occlusal component, because they can be. The digastrics, I have a slide which you probably saw when I speak about it that talks about the neuroanatomy, and the digastrics do get some input from the molar periodontal ligaments and the trigeminal motor nucleus. So it's not as predominant, as, of course, as the master and temporalis. Right. But from a simplicity standpoint, if you're set up this way, it's easier.
And
but
it's usually
case by case, you see how quickly it is to edit and make it an 8-channel. You know, you make it 8-channel very easily, and then you just have to put the leads on the face.
Ask away. You were just asking me.
I'm just curious how this is going to keep me from clenching my teeth.
Well, a lot of people stop clenching once their teeth don't stimulate it as much. So you might clench some, but usually what people say is it doesn't feel like they can do it anymore. Those when you bite down, the sense you have everything tightening down, the teeth don't really do it anymore. So it tends to relax the muscles and people stop. Now, of that, I'd say 10, maybe 15% of the people still do it, but the destruction and the sense of tightness that they get and the symptoms that they get are way less, so you live more comfortably. And it's hard to know until you actually have it done whether you will stop or become let's say, a much less frequent clencher environment. But it definitely limits the ability for your teeth to stimulate the problem. So, do you find yourself doing it at night, or is it, you know,
it's constantly, day and night.
During the day? So you find, what symptoms do you have?
I was telling him, like yesterday I woke up, I felt like somebody had just beaten me from my neck up, just sore all over.
You don't sleep well? Or
don't sleep well.
You find yourself waking up like your teeth like good. Mm-hmm. Yeah, so you'll see that you'll find that you'll have less of that. Not necessarily can we say you won't do it anymore, but if you're a physical clencher, you'll do it a lot less. If you're an emotional clencher, you still have the propensity to do it. But the degree of discomfort that you have, like what you were just describing, will be down by the fact that your teeth no longer stimulate as much pressure. So it's interesting because there isn't a way to know how much it'll impact your clenching pattern until it's actually done. And no night guard or appliance can tell us that either. It really has to be done for you. But if your symptoms are pretty regular and you clench a lot, most people say that they find that they don't do it anywhere near as much anymore. And they sleep better, and they eat better, like their chewing is easier, their stress level is when they clench and grind as opposed to being constant. So if you had like a bad week at work, you might clench as opposed to being 7 days a week, every week, every day.
Beautiful.
Yeah, so this vibration, this minor movement of the right side. Yeah, it would be very low energy, these vibrations.
So this isn't so bad.
No, this would
lands.
be, does your jaw make a lot of noise or block or dislocate? Right? So you feel all tightness and tension in your head, but your jaw joint seems to work okay?
Yes.
So how would you describe your symptoms that you have?
Yep. The cleaning, exam, and x-rays.
I don't know, I'm at a loss here.
Do you feel like your face is tight?
No, I just have it's changed in the last couple of weeks, but at first it started out just lots of like pain right in here. I thought it was my sinus or an ear infection, and now it's just my mouth is constantly just tired.
Tired. So you're fatigued and you don't have the pain anymore, or you still
Yes,
have it
I
a
still
little?
have the pain. Yes.
But it's gone from being painful to painful and tired.
Painful and tired. Yes.
And did you ever have episodes of it before, and you just showed up all of a sudden?
This summer. Yes.
Did you wear a night guard or do any of that?
I bought one of those like a football player would wear for a while, but it seemed like it moved my teeth around so much that I couldn't even chew. So I quit doing that.
Did it help you?
Yeah, I think it did.
Lessen it a little?
Yes.
All right, let's just see, and this won't hurt you. What the sensor does. Go ahead and bite home. Perfect. Open big.
All your back teeth together. Squeeze hard.
Bite
back.
home.
There you go, like that.
Good. Now open super big. Here we go for real. Bite home hard. 1, 2 seconds. Now swing right. And open big. Beautiful.
Yeah, that's a good one.
Awesome.
Again, the period, you can see where the C line belongs, and then you see where there's hyperactivity for a short period of time in the three muscles. The right temple is the longest period of hyperactivity. Let's just see what the disclusion is. The disclusion is, so it's mostly posterior right group function with some balancing component. And the center of force, I think, moved down when I watched it. Let's see. It moved backwards, I think. Let's see. Yeah, it moved backwards. So
Some kind of hang up on the right posterior.
all
Number
inside
two-ish,
lingual
three-ish.
cusps, and you know, you can see it. And there's a balancing component.
Yeah.
So for the next movement, you could raise the sensitivity.
Okay.
But the early part of the movement is definitely influencing these muscles. Even the non-working temporalis is affected. Usually you don't see that. Usually you see this flat line right here.
Really?
Because you can see distinctly where she moves very well to the right.
All right, bite home hard.
Okay.
1, 2, go left, and open big. Beautiful.
Yeah.
This
This
time
time
it worked. Now a right lateral pterygoid, but that doesn't matter because you can't mark that, right? Would be
Well,
adequate.
you know, this is a lot of activity in the left temporalis, and the right masseter is somewhat active during the excursion when she moves to the right.
Well, she's going left here.
She's going left.
Yeah.
Yeah, so there's a lot of friction, but you don't see a lot of hyperactivity here.
But we did on the other side, didn't we? 2, now come forwards. Perfect. You are good.
In protrusion, you always have some right and left shared. You know,
That's a good pattern, isn't it?
right. This is a good pattern. There's early group function on the right side that hangs around. The balancing side looks like it drops out pretty well. So here's the use and some hyperfunction, and it certainly influences her temples as well, which is rare.
Really?
Yeah, usually the temples shut off pretty well. And this just shows you a balanced bite doesn't guarantee good muscle firing patterns, right? That's one of those things that...
Has she had? She hasn't had T-scan.
Mhm.
No.
Mhm.
Yeah, so you see what happens.
But you
is-
see what he's saying is T-scan isn't enough. Just
Yeah.
because with T-scan you're basing it on numbers, time,
Yeah.
right?
Mm-hmm.
But when you sync the muscle with it, this is when you can truly prove whether it's worked or not. Just because the
Yeah.
numbers say on the T-scan that it should be better,
Right.
then all of a sudden you have the patient that's like, yeah, it helped, but it's not great.
And then you go, but look at your muscles are relaxing.
If you'd have looked at the muscle.
Well, that's what, so your next step now is gonna be to start, you're gonna, are you
To
gonna?
treat it.
Treat it,
Right.
and then do it
Then you-
after?
Yes.
And then you see the muscle changes after. So what you do to figure out the muscle shutdown time is you look at the where you reach the low levels of muscle activity, which are consistent, which is going to be like right about there. And then you can put the timeline, the D line over the timeline. So in her case, it's actually out here. But the muscle shutdown tells you a lot. Like when they really go low, under 10 like this, That's where you're really seeing, like if you look at her wrist, she has good resting EMG. They're all under 10, right? So you want to see them return to under 10, and for her, it takes a long time for that to happen,
Okay.
right, in protrusion. So that's the, this early period, no one slides all the way out, right? So
Right.
you're going to just slide very small distances, right?
Right.
So right around the central fossa is going to be the first few millimeters of tooth movement, is also the first few fractions of seconds of muscle fiber.
Right.
The E line is actually, this is a false line. I mean, it's not a false line, it's supposed to be there, but it's supposed to be the beginning of muscle contraction, which
Yeah.
would be out here.
I was like, E-line, I've never
Right.
seen an E-line.
The E line is the beginning of electrical firing. And so
Oh,
it should
because
be
you're blinking.
right before A.
Understood.
But a lot of times it shows up here, which it shouldn't be there.
That is telling us
It would be that you'd see it like right here in front of A.
firing begins here.
Right. It's like those four little lines,
Mhm.
but it doesn't match up all the time with the TC.
So ignore the E-line.
Unless it's on the front end.
Gotcha.
Because it could be like here, and you'd see one muscle firing.
I
But a
gotcha.
lot of times in the T-scan EMG, it ends up out here, which is a flaw. Not sure why.
Okay.
And sometimes the person will get pain in this area because of the temporalis attaches there. In other words, it's not just the massive. The massive is here, but the temporalis comes down through here. So a lot of times people have like sinus, she said sinus pain.
Yeah.
Zygomatic arch is where the temporalis attaches to. So this is a lot of hyperfunction. So hopefully we could eliminate that and that through treating the disclusion.
Bite home hard. 1, 2 seconds. Go right. Open big. Bite home really hard now. And now go left. Perfect.
She's very good at making the accordance, which is really good. The center of force is forward now, not as far back in the mouth, which is good. So I'm going to the right, which we're about to see. Let's see what happens. So there's a little bit of balancing. So that kind of hangs around a little bit.
15.
Just in the early.
It's looking better. How's it feeling?
Feels better.
Should feel a little more
15.
relaxed.
Yeah, it is.
If that's
I was
fair.
sitting here trying to clinch, and it's not as easy to do
Yeah,
now.
that's what I was telling you.
Yeah.
It's like hard to do it after you have.
Kind of cool.
Correct.
Yeah, it is.
So that's what you're seeking.
Yeah.
A curtailment of the muscle activity quicker than what you had prior to treating her.
When you walked in, were you hurting?
Yes.
Are you hurting now?
No.
This feels weird.
Yeah, it feels very different.
Different. Yeah. That's okay.
What are the differences?
Yeah, tell us.
Well, my obvious place on the upper right is gone. It's,
History.
yeah,
Finished.
You were used to that hitting first.
yeah, always. I can touch the back of my front teeth now. I don't think I was doing that.
That's important. Yeah.
Does it feel like you have more women back?
Yes,
And when you clench down, it's hard for you to generate the same kind of pressure?
yes.
Yes, that's the key. The things that make this process work, A, the center of force is now more forward. When she was biting before, it was over here and to the right and further back. So
Right.
moving the center of force up to the front is one of the reasons that the symptoms go away. So you should always see that. It may not be exactly perfect in the middle, but you
Because
should
you're
always see-
decreasing elevator muscle.
Because you're moving the pressures of the teeth, you're moving them from the back to the front. The muscle activity aside, this is a measure of the tooth contact force pattern. So here you see a perfect example why the COF is forward. The front teeth are now taking more pressure than the back teeth.